Good afternoon, and welcome to today's AFTD webinar, FTD Research 2025, Paving the Path Towards Effective Treatments. I'm Dr. Shana Dodge, and I'm Director of Research Engagement at AFTD. Thank you for joining us today. It has been an exciting year full of progress in FTD research, and we are pleased to present today's program of updates on how we can better diagnose and treat FTD. We'll discuss recent advances in FTD research, celebrate 2025 accomplishments, and talk about how you can make a difference in FTD scientific momentum in 2026. We'll get to the webinar presentation shortly, and just a few quick announcements beforehand. First, you should know that we have muted our audience to minimize background noise. AFTD staff are working behind the scenes, so if you encounter a technical issue, let us know directly by writing a message in the Q&A box. Second, time permitting, we'll conduct a brief question and answer session at the end of the webinar. Use the same Q&A box to submit a question. If you want to submit a question anonymously, just click the box to the left of the send button. We will try to answer as many as we can, and you don't have to wait until the end of the webinar. You can submit your question at any time. Also, this webinar will be recorded and archived for later viewing on AFTD's YouTube page and in the webinar section of our website. Before we begin, today's webinar is made possible through the support of Passage Bio. Passage Bio is a clinical stage genetic medicines company on a mission to improve the lives of patients with neurodegenerative diseases. Thank you to the folks at Passage Bio for their generous sponsorship of our work. We're fortunate today to be hearing from two people, both affiliated with AFTD, who spend a good deal of their time with their ears to the ground within the domain of FTD research. We'll be hearing from Penny Dacks, PhD. As AFTD's Chief Scientific Officer, Dr. Dacks leads strategy for AFTD's research programs and serves as president of the FTD Disorders Registry. Dr. Dacks holds a PhD in neuroscience from the University of Arizona. And our second presenter is Chiadi Onyike, MD, a neuropsychiatrist and director of Johns Hopkins University's FTD and Young-Onset Dementias Clinic. And he serves as chair of AFTD's Medical Advisory Council. Throughout his career, Dr. Onyike has worked to diagnose and care for people with FTD and other young-onset dementias. He has also conducted important research into the epidemiology and treatment of FTD and other disorders, including Alzheimer's disease and Lewy body dementia. We have a lot to ask our presenters, but first we'd like to ask our attendees some questions to help us understand our audience. Our first question is about clinical trials. You'll get a polling question asking, are you aware that clinical trials are seeking eligible participants to test potential treatments for FTD? And I'll give everyone a moment to complete that poll. Give you a few more seconds. All right, and for the sake of time, we'll move on. But it looks like the vast majority of you, 67% said yes, 22% no, and 11% unsure. Thank you for completing that. And we've got one more polling question. Did you know that the FTD Disorders Registry helps you join online research, find study opportunities, and show drug developers that the FTD community is ready for clinical trials? And I'll give everyone a few moments to complete that poll as well. Just a few more seconds. I see results are still coming in. And I will end it there so that we can move along. And it looks like it's split about half, with 48% saying yes, 45% saying no, and 6% unsure. Thank you for completing those polls. I think that really helps us understand who's in the audience today and where to guide some of the conversation. And with that, I would like to welcome Dr. Dacks and Dr. Onyike to the webinar.
Thank you, Shana. Do we have Dr. Onyike with us? There we go. Well, Dr. Onyike, thank you for joining us today. We're really excited about this conversation. You know, in preparation for this, I took a lot of time thinking about the year, reflecting on it, and it feels like this has been a year of a lot of change. Feels like a lot of just a long year thinking about how much has happened. But as we think about how much has changed, it's also remarkable how much hasn't changed. How much is a continuation of growth and progress, particularly when it comes to the FTD research space. So we're going to start off with, we're going to cover a lot of different topics, but we're going to start off with highlights from AFTD. And there's a couple reasons for why. I have to admit, this doesn't come naturally to me to start with AFTD, because to me, AFTD is most powerful thinking about the community and about everything that's happening. But there's two reasons why we're going to start from that lens. One is that we're really proud of what we've been able to achieve, and we wanted to take a moment to celebrate this with you, Dr. Onyike, as the chair of our Medical Advisory Council, as well as with all of the folks that are listening in on this webinar, because everything that AFTD does for FTD is made possible by the community that works with us, that supports us in so many different ways, and supports the research enterprise in so many different ways. The other reason we're going to start with AFTD is because the AFTD strategic plan that was released this July is a framework to think about progress. As we all think about creating new treatments for FTD, it is really easy for everyone to pin their hopes on, here's a treatment and how close that is to the market. How far away is it? When am I going to have that next treatment? And that is foundationally what our goal is. But I'm going to challenge everyone to think more broadly about scientific progress, because the reality is that when a treatment is in development, it is an experiment. By definition, it is an experiment. We don't know which one's going to work. And that first treatment that reaches the market will only be that first treatment. And if we do our job right, there will be a lot of treatments in development moving forward over time. And to me, a big part about this new strategic plan, at least in the research space, is really thinking about what is the foundation that is needed in order to have many shots on goals, many different treatments for the right people at the right time. So AFTD does have a 3-year strategic plan. This has been a long-standing process where our board resets and revisits our strategic direction every 3 years. And it really is central to everything that we do across the organization. Next slide. Our strategic plan covers the breadth of our 5 mission pillars, so not just research, but support, education, advocacy, and awareness, as well as what it takes to have a robust organization to achieve all of those things. But there's 5 specific objectives to research that I want to take a moment to share with all of you. One is improve the clinical trial readiness of FTD by cultivating and empowering a research-ready community. There is so much more that needs to be done to understand FTD, absolutely. But there is also a lot of treatments that are ready for clinical testing soon or now. And if we don't show that there's a community of people ready to participate in research, then we're not going to be able to attract those investors. And we've been very concerned about this for a while, to be honest. And there's a real balance, because nobody should feel the requirement or any pressure to participate in research. But how do we get to a place where every person out there is aware of the research opportunities that might be right for them and their family? So that's number 1 here. Number 2 is accelerate the development of scientific tools to improve access to diagnosis and to enable efficient and informative clinical trials. So how do we get scalable, low-cost tools to make it easier to access diagnosis and accurate diagnosis? And how do we make those clinical trials more efficient and effective so that they can have the answers faster on whether a treatment might work? Number 3 is accelerate scientific progress for all families affected by FTD, to make sure that with intentionality that we're looking at how all of these different efforts are meeting the needs of as many people as possible who are going down this FTD journey. Number 4 is to cultivate a robust and broad pipeline of scientific leaders when we talk about that foundation upon which new treatments will be built, this is key, right? We need those scientific leaders working on advances in understanding the disease, all the way through to scientific leaders that are implementing new approaches to clinical care, figuring out how we can make quality of life better for everyone. Number 5 is to advance research to better understand and address factors that impede well-being for all touched with FTD. You'll hear us talk a lot in the research space at AFTD about new pharmaceutical treatments, but that is not the breadth of our mission. We need to figure out ways to improve quality of life for everyone, not just new pharmaceutical treatments. And just want to also acknowledge, and this was Dr. Onyike, I know you were specifically requested this piece, that remember that everything that we do across the organization, from support, education, advocacy, and awareness, all of those pieces are central to creating that strong foundation upon which research progress is possible. So that's our new strategic plan. It's going to guide our focus for the next 3 years. Next slide. Some of this started since July 1. Some of this has been throughout since January 1. Some of the milestones that we've been able to achieve in research in 2025. And I think some of this is going to resonate with what you just heard about those different tactics, and some is going to be broader. So in 2025, AFTD brought almost $9 million in new research grants. That was made possible both by our own funding as well as by the partners. It's central to much of our strategies of really how do we bring more resources from others as well into this FTD space. That funding is, spans some early stage clinical trials, one of which is still in contracting, but we're going to frame it here anyway. We've been really proud to give out $2.1 million in a new program for diagnostic biomarkers, and that is a partnership that's made possible by several of those partners down below on that screen. We've also given out $1 million in early stage drug discovery, and that's through our partnerships with the Alzheimer's Drug Discovery Foundation. So as our clinical trials program is also in partnership with them. And we've given out over $700,000 for early career researchers to build that pipeline of researchers moving forward. Next slide. A big part of our work is not just the funding, however. It's also bringing together great minds from a lot of different perspectives and a lot of different areas of expertise to think through how do we overcome the challenges in this space. So we hosted our 3rd annual Holloway Summit on risk factors for FTD, chaired by Dr. Onyike here on this call with us, as well as Dr. Caitlin Casaletto. We also chaired or hosted our 3rd annual FTD Research Roundtable. This is an annual program really designed around clinical trial readiness, where we talk across regulators at the FDA and the EMA, the different biopharma leaders working on new treatments, the academic leaders, advocates with lived experience, and other nonprofits, all talking about how do we design clinical trials and make them more feasible, faster, and more designed around what the patients and families need to see from us. We've also been working a lot towards genetic FTD and advancing those treatments. AFTD's mission spans all forms of FTD. The field of science has evolved in much faster for certain genetic forms. So, for example, we hosted a half-day genetic symposium for the first time at the AFTD Education Conference. We worked very deeply on a publication led by Dr. Michael Benatar and Dr. Adam Boxer on the design of C9orf disease prevention trials, thinking about disease prevention not just for FTD, but also ALS that these individuals are jointly at risk for. We've brought forward a lot of additional resources and scientific publications to promote access to genetic counseling and testing. And we're the only FTD-focused member of what is the AMP-ALS partnership. This is a very large public-private partnership in the ALS space. And because so many of our community are either on the sporadic form of both FTD and ALS coinciding in the same person, or on the genetic space where folks are at risk of both diseases, we felt it was really important to have a strong FTD voice there, reminding them about this spectrum and seeing how we can incorporate the needs of people who are affected by FTD within that ALS spectrum. Next slide. So we've also been working towards leveraging resources and expanding the research community. So we have a whole program around research engagement that is designed to help individuals with lived experience and researchers understand each other so that we can amplify the perspectives and the values of people with lived experience and help researchers understand how to work with them. So we've had 24 distinct individuals who've been able to share their lived experiences with researchers in that kind of narrative story-like framework. We've also been able to expand our researcher network with over 500 new scientists signing up for communications and joining AFTD for information and resources. We've developed 2 new research newsletters that are on a new sequence here. So one is for our research community and researchers community, and one is for our community wanting to hear information and insights about research. We've also published guidance on digital health technologies to improve accessibility to reduce the travel burden in research. And that was actually the outcome of one of those Holloway summits that I mentioned as one of these annual programs around convening folks around key challenges in research. Next slide. You've heard me talk about the need for participants. Numbers have power, particularly in a rare disease like FTD. The more people that we know about, the more people that we know where they are, the better we can encourage investment in this space and the better that we can design the clinical trials that the community needs. The FTD Disorders Registry is a partnership with the Bluefield Project and AFTD, so it's a separate affiliated organization. In 2025, our numbers have grown where we had transformed our platform in mid-2024. We've grown to over 2,300 new accounts created, almost 3,000 surveys created or completed, excuse me, to learn from the lived experience of individuals. We've supported over 22 external research studies to help connect individuals to the research studies that might be right for them. And we've presented data on the lived experience of FTD in 13 different registry presentations. Some of those are at a range of different scientific conferences in different settings. Some have been at the education conference, and some have also been at the FTD Research Roundtable, where a session was moderated by a leader from the FDA who wanted to understand what is the lived experience and the perspective of benefit and risk and what matters for treatments that might be getting developed. So, like I said at the start, we're really proud of what we've been able to do with all of you and with all of your partnership and support. Dr. Onyike, you've been involved with AFTD since what? I think you said 2006. So before we move on, I wanted to just turn the mic over to you for your reflections of just where the field's growing.
So thank you, Dr. Dacks. And I should say my thanks as well to Dr. Dodge and to everyone else who's helped to pull this together. I know it looks easy to have to be on a webinar when you click a link and you join, but a lot of work goes on behind the scenes. So thank you. So this is really staggering from my perspective, what you've all seen, this overview of where things are today and in 2025. You know, as Dr. Dacks mentioned, I first really got into FTD work in 2006, so roughly 20 years ago. And you know, the AFTD welcomed me to this work by having their board meeting in Baltimore, and we all fit into one restaurant. And back then, you know, the focus was on ensuring that the physician community understood what FTD is, that there were centers that people could get to get a proper diagnosis. Our questions were about standardizing the diagnosis so that we could proceed with research in an orderly way. We knew that some people had that FTD was concentrated more in some families than in others. And we knew something of the pathology. Well, today we're not talking about treatments to ameliorate. We are now talking about cure. In a very serious way, in ways that involve substantial investments of the kind that you've seen. We're talking about a robust pipeline. We're talking about linking the FTD community professional community, researchers, clinicians, as well as the people who live with this condition, the broad community around the globe. It's fantastic. And, the influence of AFTD in terms of federal policy, funding research, the influence of FTD in the philanthropy world, and ultimately the substantial across the board investments are really, I would not have been able to dream of it in 2006. I would have taken half of it by 2025. So I'm really stunned whenever I stop to reflect on this. And it's because we've all come together, not just the researchers, but researchers can get this far if the community isn't also engaged. As we say in many African communities have the same proverb: if you wish to go far, you travel together. You only travel alone if you're trying to go fast. And I might add, very often you might lose your way. So we've come very far together. It's really inspiring. We're not all the way there yet, but we have the foundation for our big ambitions.
Thank you. So, looking at 2025, what the first question we have relates to biomarkers, Dr. Onyike. So, just for everyone's framework here, I want to remind everyone that biomarkers are really a foundational tool here, both to improve access to accurately timely diagnosis, where if you have a test for these things, you can really get much faster, more accurate diagnosis. It's also essential to developing new treatments. We have to know which people have which cause of FTD. We have to be able to rapidly measure if a treatment might be helping, if we're going to develop the treatments for everyone and not just for a few select genetic groups, all of which are essential. So we were really, really proud that we were able to bring some new funding forward from the Biomarkers Initiative. We were grateful for the AFTD Holloway Family Fund and our partners at the Alzheimer's Association, the Rainwater Charitable Foundation, and the Robertson Foundation. There's a broader framework here of just this is an exciting time for biomarkers. So Dr. Onyike, can you share with the group here what have you found the most exciting about biomarker development in 2025?
Well, so before I get into that, Dr. Dacks, I would say, I would want to add to the stage that you set by pointing out that there have been significant, first of all, there are a lot of clinical trials, and we'll get into that in a moment. Also, there have been significant developments on the genetic side that have serious implications for the risk and for identifying who's at risk and for understanding what that risk might mean. In particular, we used to think that when people had hereditary mutations, genetic mutations that are responsible for hereditary forms of FTD, that it was 100% penetrant, meaning if you had the disease, you were certain to have the disease. If you had the mutation, you were certain to have the disease. Now we know that the penetrance is not entirely 100%. The degree of penetrance depends on the genetic class. It seems for the major genetic classes, it seems the lowest for the C9 ORF72 mutation. We know that there's an age dependence in that penetrance, meaning that the likelihood of developing symptoms changes as you get older. And the risk of developing symptoms begins at about age 40 or 40 to 45. But by age, say, 70 or 80, maybe just 60% or so, 66% of people with the C9 mutation might have symptoms. So that's one. Beyond that, we also have the beginnings of an understanding of what might influence that penetrance. There's the discovery of the TMEM106B allele, which seems to influence when and how a person might develop symptoms given that they carry a mutation. Now, these things are significant because they really do have an impact, along with other factors, in the value of biomarkers. The penetrance has implications because it changes what it means to have a mutation in some ways. What do I say to a family? How do we do surveillance if somebody has a mutation? We're beginning to have clinics that are, in some areas, we have one at Johns Hopkins that are speaking to people, they're looking after people who do not yet have symptoms. They don't have dementia. They don't have mild cognitive impairment or any in-between syndrome. They're still in their lives. but they want to be under surveillance. And then the question arises, for how long and what are you looking out for?
Mhm.
As we go into clinical trials, it's going to be influential in it has an impact in clinical trial design, because then now you don't have necessarily a cutoff age as to when to enroll people. And we know that for preventive trials, we can't enroll people and observe over 10, 15 years. That's not feasible. So we need some way to time clinical trial enrollment. So all of this means ultimately boils down to biomarkers. We need biomarkers that can tell us how close a person might be. So how close a person might be to developing symptoms, given the mutation type, the family context, and even for people who might not carry a hereditary mutation. We need biomarkers to define trial populations. We'll have to do stratifications, for example, in clinical trial enrollment. What does stratification means? It means being mindful of who you're enrolling in the trial on the basis of their likelihood of developing symptoms, in order to ensure that if a trial is not successful, it's not because the enrollment was skewed against the trial. So biomarkers are crucial. Now in 2025, I think you asked what have I found exciting?
Well, I did, but I also want to, before we go there, I think some of the points that you raised are really centrally important. And I want to make sure that some of our community have understood. Just so, for example, you mentioned the variability in penetrance.
Yes.
And one of the things that I've heard as a reaction from some families are that, let's say it's a C9orf72, where there's been a new study reporting at a population level that folks who have those repeat expansions, I mean, that study showed about 20% of a risk of developing ALS. And I think that is a big surprise to most of the ALS world, for example, and that a significant number of folks don't develop other things. And some families will say, that is not my family. My family's penetrance is much higher than that. And so I also just want to frame that part of this is both, as you're saying, as a clinician advising that individual, but as a clinician, you're also talking with that family and learning what that person's family history is, right?
Yes.
To me, as a scientist, this is also telling us that there's things we don't understand yet. If it's
Absolutely.
not just explained by C9orf72 repeat expansions, what is modifying that risk? You're mentioning TMIM106B as one of those critical modifiers. What else? What are we still needing to understand? Because I think that's also going to be a key to unlocking potential treatments, right?
Uh,
It's like,
yeah, absolutely. That's we might say that's the beginning.
mhm,
People are this is an area of active investigation. And so we can expect to learn more. The positive news is that in 2025, there are there are groups around the world tackling these and other questions. Uh,
right.
but it speaks fundamentally to the individualization of care.
Mhm,
You have the family history. Some people have a family history that suggests high penetrance, and others have a family history that does not. And what we don't know are how these two families might differ in other aspects of their genetics, and therefore their biology, that might influence for want of a better term, the
mhm,
vulnerability or the resilience uh,
yeah.
to develop in the condition, given you already have a trigger.
Right. Yeah, it's also fascinating to think about as science is going to continue to expand and genetic testing becomes more available, as data becomes more available in different ways. We have been reliant on a long time with who's going to those specialist centers. Usually that's going to be the people, the families with the highest penetrance. Those are
Yeah.
the folks that are going to access genetic testing. And
Mhm.
so, as we start to be able to have other tools at the population level, I think we're going to learn a lot more. We learned a lot in 2025, and I'm excited to see what we're learning moving forward.
Absolutely. And you touch on an important point, because at some point the majority of people who live with FTD today don't have hereditary mutations.
Right.
But these mutations are, one of the reasons that research focuses heavily on them is because we know we have some knowledge of who is really at risk for developing it in the future. That opens the door to identifying biomarkers that you have biomarkers to test the effectiveness of treatment, but also biomarkers that might be predictive, that might allow us to know who is going to develop the condition that might then be transportable to the non-hereditary context. That will allow us to do larger population screening. So today, for example, you can go to you go to a wellness visit, and for men, it's the PSA that's being tested. It could be the TSH, and then based on the values, you're told the next steps clinically.
Yeah.
But what it means essentially is that a physician who is ordering the TSH doesn't even necessarily have to fully understand thyroid disease. They
Right.
order a test and they get a number back. We would very much like to be there for FTD, because that will, FTD is very complex, clinically and pathologically. It's often even very difficult to explain the condition to either to lay audiences and frankly even to physician audiences. And so simplifying the diagnostic process by having a test result that is easy to interpret, and easy, cheap and cheap to order and do
Yeah.
will make a huge difference.
I think that's also where the Alzheimer's space is really leading the way in a ways that we will be able to benefit from. And not just, there's a lot of people out there diagnosed with Alzheimer's who may have FTD, and then they have that new diagnosis and they're learning from that. But that the Alzheimer's has their first ever blood tests that are becoming more clinically available. And that in turn is both helping clinicians figure out how do they use those tests, how do they handle that conversation with that family. And in some cases, that test may be picking up a future risk of decline that isn't yet here. And that's a difficult kind of conversation for a clinician to have with a family member who may not understand that separation between the dementia you have versus your risk of dementia in the future. I think we're going to really benefit from I mean, it's just really exciting to see the progress that's coming in that space. Would you agree?
Absolutely, absolutely. And as you mentioned, the biomarkers for Alzheimer's disease are also making it easier for us to make diagnoses of FTD in cases that previously we would have considered ambiguous, and where we might have previously said, well, let's wait another 6 months and see how things unfold, which essentially means let's see how you go about getting worse in order for us to then have a clearer understanding of what the diagnosis ought to be. Now we can say, well, if the leading contenders are Alzheimer's disease and frontotemporal dementia, if you're negative on the Alzheimer's disease biomarkers, then we know it's frontotemporal dementia.
Right.
So that's already happening.
And we're going to run out of time. So I will say there's a lot of different biomarkers on the exploratory side. They're not clinically available yet, but there's really exciting progress, right, on TDP-43, on new tau PET imaging that can pick up more forms of FTD, on other types of markers.
Yes.
Shall we shift on, though, Chiadi, to
Yes,
Dr.
absolutely.
Onyike? Okay. I do want to make sure we cover a lot of different topics. So one, you and I have talked a lot about how research at the end of the day is an international experience. People with FTD deserve support and research participation opportunities wherever they may be. And in an FTD space, going beyond the ethical reality to the pragmatic research reality, we must have international clinical trials, or we will not find enough people for our clinical trials to test if new treatments work. I mean, the example of the Electra clinical trial, that phase 3 clinical trial took about 66 clinical trial sites, 3 years to recruit 100 people. Those are not the types of numbers that we need. So that's my soapbox. But the question for you is, when you look at the international landscape, how do you feel that it's changed over the past year?
Well, I think the changes really have been going on for longer than the past year, but I'll zero in on the past year in a moment. FTD research has become global. There's a lot of activity, not just in North America, but there's historically been tremendous activity in Europe. In fact, the story of FTD discovery begins in Europe. But it's there's activity in South America, in Australia, New Zealand, all in Southeast Asia and in East Asia as well, all around the globe. There are some areas where we can do more, Africa notably. But what is striking about that is the partnerships that are formed. There's explicit partnership, linking of arms between researchers all around the world. So that sets the stage for collaboration. Alongside that, as you and the AFTD know, there's a parallel linking of arms on the advocacy side. And our industry partners, who are developing the drugs that we will hope to test or that we're already testing, have considerable experience doing research trials internationally. FTD trials won't be the first kinds of trials that are done internationally. They have deep experience and they have a lot of commitment. What the singular challenge isn't really on the technical side. It's primarily on the numbers side.
Yeah.
As these compounds, so many of them are being developed or are in development. Others are already entering trials or are already in trials. And one of the big worries and what I would consider the challenge, the principal challenge is the risk that we won't have enough participants to make sure that we give every compound that's developed a proper testing.
Right. And if we don't have information like a registry to show that the people are there, then
Absolutely.
that also means the companies won't bring their trials to this space. The investors won't spend the money to start that trial if they don't think that they'll have the community ready to partner with them. And that is where AFTD, our partners at the registry, and our other partners like the emergent genetic groups like CureMapT, CureGRN, the Bluefield Project, we are all committed to having a community of folks there. And it's been really inspiring to see the collaboration of the international researchers with the FTD Prevention Initiative, for example, and folks around the globe working to see how can we collaborate in research spaces.
Absolutely. And then we have to penetrate more deeply into practice, particularly in primary care.
Right.
Because people get to the registry after they've been told they have the condition,
Yeah.
in most cases, unless they already have a family history. And so it's imperative that we identify cases, we identify people early so
Yeah.
we can give them a maximum opportunity of benefiting from treatments as we make progress.
So this has been a wonderful dynamic discussion. I'm going to jump a little bit to one last topic and then invite our Dr. Dodge to come back for open Q&A with our audience.
Mhm.
We have gotten a lot of questions at every webinar over the last year about the geopolitical landscape.
Yes.
And there is no question that there has been unprecedented change and it's sent shockwaves to the research community in a lot of ways. Right, we've had statistics where about, I think, 3,000 staff at the NIH have lost their jobs. We've had about 26% fewer grants given out in neurological disorders, for example. About over 5,000 grants were canceled or frozen, and then about half of those were reinstated. In some ways, it's been almost overwhelming. But at the same time, I've got to say that I am still so inspired by how the bedrock of bipartisan support for research, that's not gone anywhere. That's been central to the progress and the federal investment in the United States. That's still here. And the research, by and large, it's all going really well and it's continuing. And so for all the disruption and that's happened, I look over at the past year and I'm so, wow, I really feel for our folks at the NIH in particular. There are so many amazing people that I've had the opportunity to work with there over the last few decades. And just a shout out to them for, I think they've gone on this roller coaster to much more greater extent even than the rest of us. But that bipartisan support for research, again, it's the bedrock and it's here. Do you want to add or reflect on that as a clinician and a researcher and someone at Johns Hopkins?
Yeah, absolutely. I think you're spot on. There's very strong supports, bipartisan support in the Capitol for dementia research generally, for FTD research as well. Beginning with the Obama administration through the first Trump administration, the Biden administration, and the current administration, the budget for the NIH has for the NIH budget for research, dementia research, the Alzheimer's disease and related disorders, they like to term it, has steadily grown. Now there isn't a budget yet, I think, for the coming year, but all indications are that the budget is not going to be cut. Now, as we all know, there have been a lot of disruptions as the federal government is being reorganized to fit the current administration's priorities. staff at NIH, as you mentioned, have worked very hard, extraordinarily, I might add, given how they've been affected, staff losses, bigger, workloads, the
Yeah.
shutdown, and they've also been creative in helping projects get submitted, funded. We're glad, to say that the all FTD, for example, which has been hugely instrumental in a lot of the discovery that's happened over the last 5 years, has been refunded and will be going forward. The other thing that's happened is that partnerships in the private sector, and the philanthropy, also the industry commitment, has remained very, very strong, and in many cases it has grown. It has stepped into gaps. So I think there's every reason to remain confident that we'll continue to make the progress that we're making, that we'll continue to see the levels of investments that we need to continue to move the ball forward.
And I do want to take one moment to just celebrate the renewal of all FTD too. This is so important in so many ways. This is the standalone source it's a clinical research study. It's also the source of data because of the NIH policies and that single source of funding. They are able to share data to a much greater extent than any other source of information out there. And in all of the discussions we have about how do you design clinical trials so that there are fewer participants in those trials, all FTD data and innovation is central. So it was a huge relief to everyone in the community when the National Institute of Aging and the National Institute for Neurological Disorders and Stroke combined together to fund this very expensive study. This was not something that anybody in the non-philanthropic sector could have funded without the bipartisan support of the NIH. And we're just so grateful to both of those institutes. We would not have drug development moving forward, in my opinion, my personal opinion, if it wasn't for this type of investment and this type of study.
Absolutely. And to add to that, there are ancillary studies that rely on the continuation, or that will rely on the continuation of all FTD. So in fact, the NIH's investments in all FTD are going to reach beyond the commitment to all FTD itself, because all FTD serves as a platform for other kinds of discovery studies.
Yeah. So I'm going to invite our colleague, Dr. Dodge, to come back on and share with us other types of questions. If anybody would like to stay engaged with advocacy as these different types of emergent issues occur, do remember that there is an AFTD Advocacy Action Center online that you can then participate in. Dr. Dodge.
Thank you both. And I've been monitoring the Q&A box, and you've already spoken to some of the questions that have come in. So I think we're all on the same wavelength here. We did get a few questions asking about, you've both spoken a bit about trials for genetic FTD, and wondering if you could speak a little bit about trials for people with sporadic FTD or symptomatic trials, and how people can find trials to enroll. What are the steps they should take to get connected to these types of research opportunities?
Dr.
So yes, the trial landscape is actually broader than the trials for the hereditary forms. I think part of the reason you hear more about the hereditary forms is because they speak to the fundamental objective, which is cure and prevention. Right now, we don't have risk factors that reliably tell us who might in the future develop FTD. And because cure will mean stopping the neurodegenerative process, and it won't necessarily mean restoring what has been lost, it's imperative that we do these interventions early. And so that's why a lot of you'll hear a lot about these studies that we hope that successful studies in the hereditary space will be transportable to people who will then be able to be used to treat people who have sporadic forms. But we also know that treatment isn't just cure, it's also amelioration. So there are trials that are focused on sporadic as well as hereditary forms that focus on slowing the impact of the symptoms, slowing the impact of the neurodegeneration. These include drug trials. They include other kinds of trials that are focused on brain remodeling, things like brain stimulation studies. one way to find this, firstly, is if you're participating in the FTD registry, then and you indicate within the registry that you're interested in the clinical trials, then you'll get notifications through that channel. The other is to speak to the physicians that you're working with, particularly if you're at an FTD center. They generally will know of these trials. One can also go to clinicaltrials.gov. One of the caveats with that is that, the information there is not always up to date. And, always ask the old FTD. If you go to the website and ask, you'll definitely get reliable, up-to-date information about where the trials are happening.
Mhm.
Yeah.
Wonderful.
Yeah.
Dr. Dacks, anything you wanted to add to that? I don't want to cut you off.
I do want to reinforce that in some cases, in the conversations that I have with different drug developers and investors, I'm seeing an appetite that they want to do trials in this space, but they're not convinced that they'll find enough people.
Yeah.
And so when you join the registry, for example, it's not about necessarily just the trials that are already here now. And I know that's what we want. I wish that we had them now, but it's also about the trials that we can bring. Numbers have power, and
Yeah.
numbers can bring things forward. Um, and as Dr. Onyike framed, there are trials that have been happening. There was trials published just in this last year on a communication bridge approach to try to improve the quality of life for individuals with PPA. There was another trial on behavioral variant behavioral variant FTD for apathy that Dr. Elizabeth Finger had led about an intranasal oxytocin approach. There's lots of treatment ideas that people are finding that
Yeah.
people are testing. They're often smaller trials, which is why we don't beat the drum, come join, because it's easier to find people for them. So
Yeah.
we're less worried about recruiting in that context. And
Great.
yeah.
We got a number of questions. This is kind of a fun one about artificial intelligence. And I'm curious if either of you have anything to say about the role of AI in research progress, anything that you've been hearing about this.
Dr. Onyike, would you like to answer?
Yes, AI is promising in so many different ways. One of the potential uses of AI is in churning through large amounts of information for relationships that we might not have predicted, or patterns that we have not yet thought of or discerned. That might be informative. So it's helping, for example, to move risk factor research forward. It's also helping with screening. It's also potentially helpful for screening large libraries of compounds that have already been approved for other reasons that might then be useful for FTD treatments, whether for symptomatic or even for cure. We are only just at the beginning of what AI can do. Um, it's it's even helping with refining questions around brain imaging and so on. The scope is staggering.
Yeah. Yeah, I think for FTD specifically, we've also seen it being used for things like digital pathology to help with reading the autopsy results, for example, and making those more broadly available and accessible. I'm not seeing any area that it's not being at least attempted. I
Mhm.
think as a field, we have questions. I am trying to watch to a certain extent about things like AI to improve access to diagnosis. Just wanting to understand where people's data might be going. And I think that's part of our responsibility as a nonprofit, both to accelerate the pace, but also to help make sure that folks are not, say, getting denied access to insurance, something like that. It is part of why I say the registry's data is locked down. That is not being put into training models for that kind of thing. But it is a profoundly important area that we're bringing every tool that we can to accelerate this pace. And
Yeah.
as Dr. Onyike said, we're just at the start of AI, and I know I'm still learning a lot, and I'm really excited to learn more.
Great, thank you. We got a few different questions, essentially asking, can people enroll in more than one research study at the same time?
Generally, the answer will be no. The reason, firstly, is that then it becomes difficult to attribute effects, whether those effects are positive or even adverse effects. It becomes very difficult for the trials to understand what they're observing. So I think most trials virtually every trial I know of will not allow for you to be in another trial simultaneously. Now, what they will allow in many cases, in most cases, I think, is for you to continue standard of care treatments. So if you're already on a treatment that's been helpful, whether it's you've seen benefits for cognition or benefits for function or behavior, most trials will let you continue that. They might have caveats about changing doses of things, but they'll let you continue. But
Yeah.
being in two experimental treatments at the same time is not allowed.
And we have heard of community members, not in the trials, but in, say, natural history studies, like
Yeah.
folks who are at risk of both FTD and ALS, maybe participating jointly in both types of studies. I think it is really important that you tell the investigator if you're doing that, because as Dr. Onyike said, that can, like in many cases, it's going to be fantastic and they'll be grateful for it and there'll be tools later for them to figure that out. But depending on how they've set up their study, that can create difficulties with how the data is then combined. So for example, if they're pooling the data across the two studies and they have the same person in both, that can complicate things. But you know, you don't know if you don't ask the investigator. So like kudos to those folks that are really leaning in and doing everything they can to accelerate by participating in everything that they can. Just check with the investigator, let them know.
Yeah.
I think we have time for probably one more question. And we had a few that were along the topic of seeing drugs being tested in other disease spaces that seem relevant for folks with FTD. So there was a question about TDP-43 research. There was a question about tau research being done in Alzheimer's. And I'm wondering if either of you have any thoughts about what can be done to see if these potential therapies could be tested in a population of people with FTD.
Yeah, let me take the tau example because I think that's the very important one. We within the FTD field, there isn't a very the pipeline for tau focused therapies is fragile for a variety of reasons. And so there's a significant reliance, and I think reasonably so, on what is coming from the Alzheimer's disease field because Alzheimer's disease also involves abnormalities of tau. And so it would be helpful. And then so we expect, or at least we hope, that some of those treatments, if they're proven in Alzheimer's disease, where populations are much larger and therefore it's easier to ask to put these things to clinical trials. And I think that's a large part of the reason why industry focuses some of the industry focus their tau-based compounds on Alzheimer's disease. It's a lot easier logistically. We hope to be able to piggyback on some of that discovery. Now, it's not going to be very straightforward because the isoforms, meaning the varieties, if you will, of tau differ between Alzheimer's disease and frontotemporal dementia. And so we can't assume, given that there'll be differences in the intracellular, what happens within cells and outside the cells. According to these varieties of tau, we can't assume that they will necessarily be effective in FTD, but we still think of it as progress. And the strategies have been developed to take advantage of that.
Yeah. And I would just add that the observations that behind this question are frankly a huge driver behind AFTD's new strategic plan when it relates to research. Because we've seen programs that we've helped fund based off of FTD preclinical models get to the clinic and get focused on ALS or get focused on Alzheimer's. And it's not that folks don't care about FTD. I really don't think that's why. There is a lack of tools. We need clinical trial readiness as a field so that folks know that they can test their treatments in this space, that we have the biomarkers we need, the outcome measures we need for the trials, the active informed community ready to participate in research. The longitudinal data, all of these things are central to convincing companies that their treatment can work here. And I personally would argue that many of those treatments, there's overlap in the biology across some of these different age-related neurodegenerative diseases. And in some cases, like with tau, the FTD may be more likely to have just one cause instead of multiple causes, multiple complex etiologies. Like with Alzheimer's, you have amyloid, you have tau, you have other things as well, or high rates of co-pathologies, for example, that can drive decline. in FTD, if we can get this right, I think folks are going to have a better chance of seeing if their treatment works in FTD, and then they can apply it elsewhere. We're not quite there yet.
Thank you both. If we can bring up the next slide to round out the questions we've gotten from the audience. Dr. Onyike, could you help us understand some concrete steps audience members can take to help propel the science forward?
Absolutely. Engagement it comes down to engagement, really. It comes down to participation. As you've heard, we're not, FTD is not a very common disease. It's not nearly as common as Alzheimer's disease. And so it's essential that we're all rowing together. It's essential that people are participating. We can't develop these treatments if people are going to be able to be identified as having the condition or as having being at risk for the condition. If we're not able to get them to participate in clinical trials, then there is no pathway. There will be no pathway to developing cure. And so there are so many ways in which one can help us. And when I say us, I'm saying the research community, the advocacy organizations, the clinicians. Us really truly means all of us together. But for the point I'm making, also on the professional side, need you, the people who live with this, the families, to participate where you can. Whether it's by putting your hand up and saying, I'm here and I'm available to participate, for example, by joining a research registry or by letting the doctors that you're working with know, whether it's by, considering genetic testing, especially for those who've been diagnosed, but for some who are very keen to get into preventive trials, you might have to, it would be important to consider testing in advance of diagnosis. Genetic counseling is essential to that process, I want to point out. But fundamentally, we need you. We need you because we need numbers. As Dr. Dacks has repeatedly said, numbers speak. They speak to the industry, our industry partners, because it tells them, look, their efforts will not be lost for want of a population who's ready to work with them. It's important to policymakers because that's how we let them know that this is an important condition to invest taxpayer dollars on. Mm-hmm. It's important to philanthropy as well because they want to see that we are ready to go, that we can get somewhere, that it is feasible to find a cure in the foreseeable future.
Yeah.
Well, I really want to thank Dr. Dacks and Dr. Onyike. I know we can't answer everyone's question here live today, but we encourage you to reach out to our helpline. If we could bring up that next screen or that next slide with the helpline information, thank you. The number is 866-507-7222, or you can email info@theaftd.org. And next slide. You've heard a lot today about the FTD Disorders Registry. You can visit the registry or enroll at ftdregistry.org. There's also a QR code, but I know it can be difficult to scan those right away. So we welcome you to visit ftdregistry.org as well if you don't have a chance to scan the code. And then next slide. We also want to share details of our next webinar, which will be focused on raising awareness through advocacy. That is scheduled for January 28th, 2026 at 3 p.m. And we'll be providing details in the coming days. We hope you can join us for that. And finally, please let us know if you have any comments or questions about today's presentation. This concludes our webinar, and we want to thank you for joining us. Please enjoy a wonderful holiday season. Thank you.
Thank you all.
Thank you all. Thank you.